Well, welcome everybody to Optometric Education Consultants National Webinar Series, Sunday night edition. It's our great privilege and honor to have Dr. Kelly Malloy talking neuro ophthalmic cases. Dr. Malloy holds the rank of professor at the Pennsylvania College of Optometry at Salus University, where she specializes in neuro ophthalmic disease. She's the chief of the Neuro Ophthalmic Disease Specialty Clinical Service at the Eye Institute and co-director of the Neuro Ophthalmic Disease Residency Program at PCO Salus. She has achieved diplomate status in the specialty with the American Academy of Optometry, the first and only. Besides her clinical patient care responsibilities, she also teaches in the head and neck anatomy, neuroanatomy, and neuro-ophthalmic disease courses at Salus. So with that, let's give Kelly a nice virtual round of applause as we welcome her in. Kelly, take it away.
Thank you so much, Joe and Greg. It's a pleasure to be here. It's a pleasure to be speaking with you all tonight. We're going to be talking about neuro-ophthalmic disease cases, and this is going to be a variety of cases and some new things in the literature to keep you up to date. I first want to say that I am a consultant and speaker for Osmotica Pharmaceuticals and RBL Pharmaceuticals, but that has no association with anything in this lecture. We're going to jump right into case number 1. This is a 5-year-old girl, and she had a routine eye exam 3 months prior in the pediatric department, but at that point, her parents were unable to stay for the dilation. So she's just here today in the pediatric department for her dilated fundus examination. And this is going to really hopefully hit home the point that we really need to do dilated exams even on children. And the reason that she was sent to me from the pediatric department was because there was a complaint of some headaches. And the mother says, well, occasionally she complains of headaches, but they've not really affected her daily activities. She's mentioned it to her pediatrician, who didn't seem very concerned about it. And she really only complains of these headaches sometimes when she's at school. And she's 5, so she's in kindergarten, right? And her mom's just like, I don't know if she just, says that because she wants to come home from school or if it really is anything important. She only complained of the headache once on a weekend, but she was in the mall, she was hungry, and her mom said I gave her food, and then she felt okay. So it didn't really make much of these headaches. If you look at her afferent exam findings, they're normal, right? Nothing there of concern at all. And really the same thing with her efferent findings. She's only 90% abduction in each eye, but when you do your cover test, she remains comitant. She's ortho, even in lateral gazes. So that 90 versus 100 is not showing any more ESO, so it's not indicating a true abduction deficit. She has a little bit of nystagmus in lateral gazes, but it's physiologic. And how do we tell that? We tell that because it's symmetric in right gaze and left gaze, and also because when we have her look all the way in lateral gaze, we see some movement, and then we have her come in by about 30 degrees, and then the nystagmus stops. And it does that on both right and left gaze. So we know it's physiologic, and that is really nothing of concern. So you might say, all right, well, we just have these headaches, and they don't really seem all that bad. Why are we even presenting this case? Well, the reason is we take a look at her nerves now. And the people in the pediatric department that initially referred her to me just said, it's hard to get a great look because she's 5, but we're just questioning. These nerves look a little concerning, especially in light of the fact that she's complaining of some headaches. So we need to know, do we need to do anything about this or not? And so this is what you could be faced with in your practice with this 5-year-old girl who comes in for her routine eye exam. When we look at the features, right, some of the features that we would expect to see if it really was papilledema, we'd be looking for what? Well, we'd be looking for patent lines, which would be these circumpapillary folds that would always be temporal. And we look and we don't really see any of those patent lines. Another thing we'd look for is obscuration of the vessels at the disc margin. And we follow all these vessels and you say, well, none of them really look all that obscured. Well, that's good. But we do see elevation. Now we can see that by this sheen here, but she's 5 and she's going to have that. But this circular area just tells us there is elevation. But when we really look, are the margins distinct? Well, we see superiorly, they're a little indistinct, maybe a little inferiorly as well, and in both eyes. So what do we do? Well, we'd want to look for a venous pulse. It's going to be a little tough to do in a 5-year-old. Some of them can sit pretty still though. You want to look with your direct ophthalmoscope. That's going to give you the best view. And we did, and we're not able to appreciate a venous pulse. So we need to really do more to see, is this concerning or is it not? So the next thing we're going to do is hopefully she's going to be able to sit for an OCT, and you can see she did pretty well in that regard. So we're able to get an OCT, and as you know, in children under the age of 18, there are no age max norms. So you really can't just see, is it in green? You're going to have to know what the normal numbers are and should be. So when you look here, if you were to look at this and this was your patient, would you be concerned? So there's certain areas you're going to look for. You're going to look at the average RNFL thickness, and we have a 116 and a 126. And you're going to need to know, is that within the normal range or is that elevated? And then you're going to look down at the clock hours as well and see what's the highest numbers we have. And you can see we have numbers as high as 208. That's starting to get a little concerning there when we see those elevated numbers. So it's important to realize what is, in children, the mean average RNFL thickness. And this article by Yanni did a study on North American children aged 5 to 15, and they found, when looking at from the 5th to 95th percentile of children, that the mean peripapillary RNFL thickness is 107 to 108. So if you can remember that number, that's going to be very helpful. Now, it doesn't necessarily mean that everybody above that has papilledema, but at least you get to know how far you are away from that mean deviation, okay? So definitely a very important number to know. Now, when we talk about adults, we have age match norms, and this number is going to be significantly higher than what we see as the mean average for adults. And the reason for that is we have the most axons when we're born, and as we age, we continue to lose axons, normal part of aging. So when we compare the 116 and the 126 to the mean normal peripapillary RNFL thickness of 107, we see that she is elevated in both eyes. So now we're going to have to try to figure out why. Now, if you look at her disc area, her discs aren't necessarily small. So we're not really dealing with hypoplastic discs, as could be the cause. We didn't see any drusen. Now, keeping in mind that at this age, drusen would still be buried. It wouldn't be until you get into the early teen years that the drusen would start to come forward. And again, when we talked about our clock hours, we pointed out how those numbers were a bit elevated and where, superiorly and inferiorly. And we have to remember that in papilledema, those are going to be the areas that swell first because they have the thickest neurofibrillary bundle. And when we have more axons there to swell, it's going to show more elevation. So superior and inferior swell first, followed by nasal, and temporal will be the last to have that in this margin in papilledema. We went ahead and ordered a scan because knowing that she's above this average mean RNFL thickness and she's getting headaches. Now you saw her papilledema, it was subtle, right? We were like, is this papilledema? Is it not papilledema? And we had to go through these step by step. We didn't see some of the features of papilledema, but we saw the superior and inferior margins being somewhat distinct. And you can see here, unfortunately, she had a significant pathology as the cause of her mild papilledema. And this was medulloblastoma with drop nets. So medulloblastoma is a cancer, not just a tumor, it is a cancer of the fourth ventricle, as you can see here. It's putting mass effect on both the brainstem and the cerebellum, and this is causing her increased intracranial pressure. The drop nets are, since this is a cancer, it can have metastases, and this metastasis drops down the spinal column to the low spine and proliferates there as well. So
hey, Cal, can you do me a favor? Can you do me a favor? Can you go back to the OCT?
Which?
Well, one more, keep going, right there. Now, I listened to Joe because I know you guys are two neuro kind of experts or, neuro god and goddesses or goddess. Joe references on this kind of Zeiss printout that the Patriot sign, is that something that, Joe, you've come up with, or is that something in the neuro space that you guys talk about?
I'm not
It
familiar
is
with
something,
that.
it is something I came up with. We're
So
trying to get
Joe
into the,
references that red, white, and blue up there, Kelly, around the
Oh,
around the
yes.
nerve as
Mhm.
kind of the
Yes.
Patriot sign, I guess. So
Yeah, so I do use this as well, looking for this colored ring, but I've never heard of it called the paper sign, but that's a name.
well, that's because I invented it. So if you don't mind start using it, I appreciate it.
Okay.
he gets no royalties.
Yeah.
All right, thank you.
Oh, you're welcome. So ultimately, she did undergo surgical removal of her tumors. She actually had to have chemotherapy and radiation as well. I saw her about a year later. She was doing well at the time. Papilledema had resolved. She was treated, but this is a cancer and definitely has the propensity to recur. And I've not seen her now with the pandemic and everything. I haven't seen her for a few years, so I'm not sure she's. But importance of doing dilated exams on kids and not assuming that just because their nerves are a little, funny looking, that it can't be papilledema because they're young. Because unfortunately, even kids can have mass. And this again is what we're seeing. This is her hydrocephalus, obstructive hydrocephalus. It's obstructing the flow of the CSF through the fourth ventricle here. So we have her lateral ventricle and her third ventricle getting very large. And here's the dilated subarachnoid fluid in the optic nerve sheath that's causing her papilledema. And this is her status post her surgery, chemo and radiation. And you can see the tumor is now the bulk. She still has large ventricles at the time just because they were so expanded to begin with. All right, so here's your first poll question. It's going to be popping up. What is the mean peripapillary RNFL thickness in children? Is it 87 microns, 97 microns, 107 microns, or 117 microns?
And the poll is launched, Cal. I know you can't see it, but it's launched. We have 78% of the people have already replied. We had a question roll in. It says, sorry, how were her pupils?
Pupils were fine. No relative afferent pupillary defect, and they were isochoric as well. But remember, with papilledema, we don't expect to see any abnormality of the pupils. And in fact, the whole entire exam can be completely normal until you look in at the nerves. So important, really looking at the nerves and getting a good view. Very good. So almost 90% of you got the correct answer here of 107 microns. So it's an important number to remember. So you can just kind of glance at it and get a sense of, are you within that expected range or not? All right, I'm going to jump on to case number 2. This is a 40-year-old male, and he presents emergently because of progressive vision loss that he's noticed in his left eye. He's noticed this for about 3 weeks. He describes it as a blur and darkening of his vision. He's not had any pain in the eyes, any headache, or any other real neurologic symptoms at all. It's mainly just, I'm losing my vision. He thinks it's mainly in his left eye. He's undergoing some stress with his job, and he has some high blood pressure, which he's trying to control with diet and exercise. He's not on any medications, and he's not had any previous eye problems. So when we take a look at him, and his visual acuity is 20/25 in that right eye and 20/40 in the left eye, and that's the eye he's complaining of. And he does have a relative afferent pupillary defect in the left eye, 0.6 log. We do confrontation fields, and we're finding constriction not just in the left eye that he's complaining of, but in both eyes. It's more severe in the left eye, but it is temporal in both eyes. So we have temporal visual field loss in both eyes. Already the little bells and whistles are going off. By temporal defect, we're thinking a supercellular type of a lesion for the most part. He does have red cap to saturation and brightness to saturation in that left eye as well, going along with his relative afferent pupillary defect. And here is his visual field. And you can see it is a bilateral process, but it is more significant in the left eye. Now, when we see this isn't the typical bitemporal presentation you may think of when you're thinking of something like a pituitary adenoma. We have to keep in mind that even though we expect it to be bitemporal, if it's left long enough without being treated and surgically removed, eventually it's just going to take up more of the visual field. So the fact that we're seeing this respect for the vertical, but it's only in the right eye, that still has to make you think about those crossing nasal fibers in the chiasm. And you're still going to be thinking of the suprasellar cistern. Now, the difference in mean deviation between the eyes being -30 in the left and about -10 in the right, that definitely goes along with the relative afferent pupillary defect, even though we didn't see it to be as large as one would expect based on the visual field. We can call this a left junctional scotoma. And that's what I was pointing out. When we only are seeing respect for the vertical in the one eye, this is as if we're thinking about the left optic nerve is damaged, and we're getting those crossing nasal fibers from the right eye being affected. So this is making us think, well, the anterior portion of the chiasm is potentially affected. So where
So
this
Cal, can we chat about those visual fields real quick? My understanding is when like that's a 30 and that's a 9, like about a 3 difference should be able to create an APD. Obviously, if one was like a 9 and one was a 6, it would be in the 9 eye.
Yes.
I kind of find it to be kind of a 5 difference where I can see it clinically. I think I can see it with it, but is that kind of your understanding? It's about a 3 difference between the eye to get an APD? Right,
because the smallest amount of APD you can see is a 0.3. When you have the neutral density filters, if anybody has the neutral density filter bar, they come in 0.3 increments, with the lowest being 0.3. So if you have that and you are wanting to create an APD, not that you can really create one, but mimic one, let's say, and somebody that has normal function of their optic nerves in each eye, and you hold that up, you can make yourself see that there's going to now be a faster escape when you hold up that 0.3. But if somebody has less than a 0.3, you're not able to really appreciate that it has a little bit of a faster escape. Okay? All right, so we want to keep in mind that when we look for the APD, what we're actually looking for is the faster escape. Okay, so remember, it's not which pupil is bigger, it's not how much it constricts or how much it dilates, it's time. So you're going to be counting the 3. And so you do a 3-second test and you think about on which number do we have escape in the one eye and on which number do we have escape in the fellow eye. So if they're not escaping at the same time between 1 and 3, then one of them, one that's the faster escape, has a relative afferent pupillary defect.
Thank you.
You're welcome. All right, so when we look here, we see that in this case, this would be the optic nerve has this lightning bolt on it. And you can see this dark blue line is also being affected by the lightning bolt. So this would be our inferior nasal fibers that are going to cross most anteriorly in the chiasm. And then we're going to see that as this inferior nasal, it's going to be superior temporal. And that's why if we have a pituitary adenoma pushing from the bottom in the inferior nasal fiber, in the visual field, it's going to be superior temporal. So when the pituitary adenoma first starts, we get superior temporal defect in both eyes. So OCT is going to be very helpful in this case. We already are thinking, because of respect for the vertical, even though it's only in one eye, we're thinking suprasellar region, suprasellar cistern. And you might think, okay, so we're thinking pituitary adenoma, but we're going to have to think about how urgent is this? And you might not really think about that. Usually you might just say, okay, I have to figure out as a pituitary adenoma. And then, I've done my job of making the diagnosis and then I send it off. But there's more to it than that. We have to realize how quickly do we have to send it off? And what's going to help us with that is OCT. Now, in this case, this gentleman had some difficulty fixating because of his field loss. And you can see that this is not the best OCT by far. Some of it is not usable, but in each eye, we're able to use something that is very helpful. So if we look at the optic nerve OCT on your right, even though the right eye is just bad, and you have to make sure you're really looking at these scans to see that there's no data at all. And you might say, oh, it's in the white, that means it's thick. Well, that doesn't match with where the line actually is. These are all zeros, right? So there's actually like nothing even measured. We can't even use this right eye here. But if we look at the right eye ganglion cell, we were able to get a good picture for that. And we can see that that still looks normal in thickness. And that's going to be very helpful. And if we look at the left eye, even though our ganglion cell is very bad, it's a very bad scan, you can just see it, there's artifact, it's just not a good scan. But if we look at the left eye on the RNFL, we're able to get a fairly decent scan, and we can see that this gentleman still has some flush RNFL tissue. So this is telling us, by using the RNFL in the left eye and the ganglion cell analysis in the right eye, that both eyes still have intact axons. And that's very important. He's having sudden vision loss with the visual field being this bad, but yet his axons are still intact structurally. That means he's able to get, we think his potential for visual recovery is good if he has surgery quickly. Okay, so this is going to be very helpful in telling us how quickly we're going to have to jump on this and get this person into surgery. And this study by Helen Dinesh Meyer talks about OCT and its use in predicting recovery, visual recovery for pituitary tumors. And it tells us that long-term visual recovery after surgical decompression can definitely be predicted by the pre-op OCT, RNFL, and you could use the ganglion cell as well. Now, when they have surgery, when they have pituitary adenoma resection, they can continue to get visual recovery for some time, but most of the recovery is going to happen in the first 6 to 10 weeks. And this is the appearance of our patient's optic disc. And this can also be helpful in predicting recovery as well. Look at these optic discs. They're nice and well perfused. They're very pink. There's no indication of pallor. There's no significant cupping. So if you just looked at these nerves, you'd say this person should have good visual function, right? But yet you can see his fields were not very good at all. So if we can stop that compression of that chiasm, surgically removing the tumor quickly before he gets permanent damage, he has the potential for very good visual recovery. So it's going to be very important to think about that aspect as well. Because if you say, all right, I made the diagnosis, now I know it has to get in the hands of neurosurgery, I'm just going to tell my receptionist to get them in with neurosurgery. Well, the person on the other end doesn't really understand, what's happening. So they're just going to schedule the next appointment if that's what you ask them to do. And that could be a while down the road. So we need to make sure that we communicate with the neurosurgeon ourselves when needed. So you'd have to ask yourself, what is this in this case? Is this a medical emergency or is it not? And you might be thinking, well, you didn't even do a scan yet, right? You're thinking it's a pituitary adenoma, but don't you have to do the scan to make sure? And that's kind of what the question is, because if you're thinking it's a medical emergency, you're not even going to get the scan, right? So let's find out what everybody thinks. Do you think it's a medical emergency or do you think it's not? If you're saying you think it's not, then you'd be saying, okay, I'm going to order the MRI and potentially some labs, get them back. And then if I confirm it's a tumor, then I'm going to call up my neurosurgeon. If you're saying, I think it's a medical emergency, then you're going to say, well, I'm not going to do any of this as an outpatient. I'm going to call the neurosurgeon now. And you might be saying, well, what if I'm not right? What if it's not a pituitary adenoma? But based on all the evidence that we have here, you'd have to think, how certain am I? So let's see what you thought.
Yep, they're rolling in nicely, Cal. I got it launched, and I think that's a good number to have. Looks like most people, they're still coming in pretty good. All right, I'm going to end it. I'll share it. So you can see what the majority feel.
Good. So 3/4 of you, very good, are saying that you think this is a medical emergency after what you've heard. So very good. All right. So again, just kind of reiterating what we said, because of the visual field defect and that respect for the vertical, even though it was only in one eye that was respecting the vertical, we know it localizes to the stellar region, to the optic chiasm. Because the visual field loss was so dense and both so superior and inferior, we know this is a large lesion, okay? And then the OCT really helped us tell that we think the prognosis, the visual prognosis is good if surgical intervention can happen quickly before this vision loss becomes irreversible. So this makes it be urgent, right? So this may beg the question, when should neurosurgery be contacted urgently or emergently in the case of a pituitary adenoma? Because that's not usually one of the things we put on, oh, this is emergency, unless maybe you've heard about pituitary apoplexy, and that's probably what you think of when you think of pituitary tumor as an emergent situation. So question is, when should neurosurgery be contacted urgently or emergently in regard to stellar lesions? Well, there's actually 3 things. Okay? One is the apoplexy that you've maybe heard about or learned about. And when you would think about apoplexy, would be sudden onset severe headaches, vision decline, being lethargic. Another reason would be if they have significant endocrinopathy with fatigue, hypotension. You're not probably going to be as much into that as, say, the endocrinologist would. But where you're going to be dealing with is answer number 1 here, acute vision loss. So anytime there is acute vision loss, it becomes an emergent situation, okay? So this is acute vision loss in terms of the afferent visual function. So how do you get this done? How do you contact them urgently or emergently? Well, based on where you're practicing, you should get to know who is the neurosurgeon in your area at the closest hospital or the closest big hospital, and get acquainted with them, because they definitely appreciate you calling them and saying, this is what's going on. And in this case, that's what I did with this patient. And they said, send them right over. They didn't say, I want to get a scan first, or I want labs first. They said, he needs surgery, let's bring him over. And when he gets there, they do the scan. And then they just keep going from that and get him into surgery.
Kelly, I want to echo that, because one of the difficulties I'm having in my new practice, and I'm still relatively new here, is getting people to take on my brain tumors.
Yes.
So, and also getting in my area, the Sarasota, Venice area, healthcare resources are relatively thin compared to the population. It's an older population, and getting in as a new patient to doctors is very challenging.
Yes.
Now, one thing that I have found, though, is if I have positive imaging, I can get through a lot quicker.
Yes.
If I have an MRI that says there's a dissection,
Oh, yeah.
I can get them in stroke neurology right away.
Right.
Otherwise, it's going to take forever. And if I find that if I have positive imaging, I've got a better shot at getting the patient in with a neurosurgeon than if I don't have that. That's just my area.
Right. And I guess it also depends on your area where you are, how long it takes to get in for the imaging. So for instance, in this case we were dealing with, if I was in a location where I could call up and get imaging that same day, then maybe I would do that. But when you're talking about a few weeks to get imaging, then obviously you don't want to wait that long, because then the patient could have permanent vision loss. But yeah, I definitely agree with what you're saying, if they have the positive imaging. Now again, you have to have a relationship. There are neurosurgeons that we use very frequently, and then they get to know you, and once you've sent a few people and they realize that, okay, you know what you're talking about, then they're going to answer the phone when you call, and they're going to see your patients. So we can
in the chat box, Cal, someone wrote, if you were ordering the imaging yourself, which I know that you do in most cases, it says, what would you order? And then Joe, obviously, if you want to weigh in after Kelly.
So if you're thinking there's a pituitary adenoma, you're gonna order an MRI as long as the patient doesn't have any contraindications to having MRI, right? So they can't have a pacemaker, they can't have any metal foreign bodies, those types of things, right? So there are different things they can't have, but as long as you've made sure there's no contraindication, you'd want to do an MRI with and without contrast, and you could do pituitary protocol if that's what you're thinking is going on. And that's what this patient here had. Now, these are the images that were done. We sent him directly to the hospital as per the direction of neurosurgery, and they did these images there, and then he went right to surgery. You can see there's a large pituitary adenoma. It's pushing up the chiasm. So normally, if we're looking at a coronal section here, the chiasm is going to look like a horizontal bar. We don't see that because it's been pushed up by this large pituitary adenoma. Okay. And here you can see a sagittal, mid-sagittal section with contrast. You can see how large this is. Again, we don't see the chiasm. And here you see an axial. So in all three sections, we're able to see this large pituitary macroadenoma. Surgical treatment, most of the time now, especially some of the neurosurgeons that we use, more often than not do endoscopic endonasal approach. Okay, so it's less invasive. They're going through the nose, and there's different ways they can do that. They can do the unilateral approach, where they're just going through the one nostril, or a binaural approach, where they're going through both nostrils. And they can do some more specialized techniques, going through and then kind of angling the endoscope, as you can see here, depending on the size of the tumor, would help them realize which type of approach they needed to do. And then once surgery is done, so this patient did have surgical removal, they need to be evaluated and managed from a lot of different standpoints. We're going to fall into obviously the vision bucket. They need to be managed for that, as well as making sure they don't develop diabetes insipidus, that their cortisol levels are normal, that their antidiuretic hormones are normal, and not have nasal issues, because they're going through the nose, but then they have to go through the sinus as well, make sure there's not any stuff leak after that. So when we're managing them from a vision standpoint, we're looking at both the afferent and efferent system. So if this is where your pituitary gland would be here, and then we can look at the green arrow, it could grow upward, as it did in this case, push on the chiasm. But we have to also remember, what a lot of people forget, is that the pituitary gland sits right between both cavernous sinuses. So if it starts to grow laterally, it can grow into the cavernous sinus. So they could develop efferent issues as well. A sixth nerve palsy would happen first, because that sits most immediately in the cavernous sinus. And then potentially you could also have a 3, a 4, B1, B2 being affected. They sit in the lateral wall. So we'd want to make sure when we're seeing them after the fact for their post-op follow-up, that we're also doing our cover testing, our ductions, and making sure there's nothing indicating that it's growing laterally as well. Okay? Because if you see something new, neurosurgery wants you to let them know, so they could get another scan and look and see what's going on. So now this is 1 month. Right? Remember, we said most of their improvement is going to happen in 6 to 10 weeks. This is 1 month later, in the hands of a very talented surgeon, as you can see. Look at this visual fields. He would have never told that there was anything there. And these 20/20 in each eye, his fields are completely normal. His color vision is normal. So he did very, very well. He had some low cortisol levels, for which they started on the decadron. He's good with endocrinology. But from a visual standpoint, you would never even know there was a tumor there. And you can see his OCT. Now it's a little bit of a better study, because you could see where he was looking a little bit better. And you can see he's got a little bit of thinning, but for the most part doing very well. His nerves are still looking great. And even though it's been a month, there's been no pallor.
Is there binasal dropping out there, Cal, on that GCC? Is that kind of that?
I mean, you know, the one eye, but not anything definitively. And I think when he came back,
the color, the yellows, and the one above it, and rather than the numbers going a little higher.
Right. Yeah. And I think when he came back, like the next visit, there was some variability to his OCT, and there was nothing indicating
Interesting, Kelly, if you were going backwards
Mhm.
and you started here, the fact is, Greg points out, there seems to be a nasal loss here, would be concerning to me. I mean, it would be worth pondering this whole issue. Just based upon this, if we
Mhm.
went backwards, I would think, all right, I might be finding something on the visual field that's not quote unquote glaucomatous.
So I
Right.
guess what we're trying to say to the audience here is that, you get a bitemporal defect, but you get a binasal kind of dropout there of the GCC. So
Right.
but that right eye is not as convincing. If you want to, maybe, I don't have a pointer. If you go up there, Cal, maybe to that top one there, keep going up to the, right there. That's,
you're
you
talking
can-
about up here. Oh, okay.
yeah, there you go. You can see a little
Hmm.
bit of dropout there. There's a little bit of kind
Yeah.
of some binasal there, but definitely there. So going, as
Yeah.
Joe's saying, going backwards,
Right.
maybe concerning there, because remember, bitemporal to the
Mhm.
audience, bitemporal creates a binasal defect.
And what I'm saying is, if I were to look at this on a patient, that this was done for me, I would say, I would hum at this one and think that there could be something, though I acknowledge I could be wrong, but I'd actually be thinking about it.
Right. I mean,
Very
we
cool.
would definitely have to explain what's going on here. And especially corresponding kind of over here temporally, it would make me think there's something maybe papillomacular bundle that has to be looked into. So in terms of chiasmal syndrome, we have to keep in mind that even though our patient's nerves looked completely normal, as say does the one down here on the bottom left, when we have compression of the optic chiasm, we have to remember we can get cupping. And therefore, you can start to see field loss and kind of sometimes be tricked into thinking it's glaucoma because you have big cups, okay? So keep in mind that all cupping is not glaucoma, and we can have it from compression, specifically compression of the chiasm. And we can also have pallor as well. So if you're thinking somebody has glaucoma, and they have some large cupping and field loss, and then you see that there's pallor of the remaining neuroretinal rim, they deserve imaging to make sure there's not a compressive reason for their cupping pallor. So in terms of, I think this is what the question somebody asked. So if they didn't have this acute vision loss and we didn't call it an emergent situation and we were going to do the workup on our own, what would we do? So we would do, as I said, MRI, pituitary protocol. So MRI the brain with pituitary protocol with and without contrast. And then neurosurgeons, if you do get the imaging and you say, okay, there's pituitary adenoma, and you're going to send to neurosurgery, they want all the blood work done as well. Because in some cases, if it's a secreting hormone, it can be treated medically. They need to know that before they decide to cut, right? Is it something that can be treated medically or not? So if you have enough evidence to say, I think this is pituitary adenoma, I'm going to get imaging to look for it, you're also going to order the labs at the same time for all the pituitary functions. So you're going to get prolactin, cortisol. Now, keeping in mind, when you're ordering something like cortisol, the time of day that it's drawn is very important, okay? So that's going to be something that you have to make the patient aware of. You have to get this test done in the morning in order to get a more accurate cortisol level. The ACTH level, the IGF-1, so insulin-like growth factor 1, growth hormone, TSH, and then the luteinizing hormone, follicle stimulating hormone, and then the testosterone and estrogen. Those are the things that neurosurgery wants besides the imaging. So these last two cases really demonstrated to us the importance of the OCT in both making a diagnosis and helping diagnose, for instance, papilledema in the first case, but also in helping us understand the timing of the treatment. So if we have a really good OCT remaining in someone that has really poor visual fields and starting to have vision loss and it's pituitary adenoma, that makes it be emergent. We've got to get them in to get that surgery right away so that they can have the wonderful outcome that this gentleman had if it can be taken care of in a timely fashion. So use your OCT to its full potential and be aware of the norms and the artifacts as well. All right, here is your next poll question. Which of the following is a reason for emergent neurosurgical referral for pituitary adenoma? Is it optic disc pallor, optic disc cupping, acute vision loss, or acute diplopia?
The poll is launched. You're caught up on questions. So just
Now,
kind of
all
let
of
it
these
roll.
things, oh, I'm sorry.
Go ahead.
All of these things can happen with pituitary adenoma, but only one of them makes it be an emergent neurosurgical referral. And which one of those would it be?
I did launch the handout at 7:14, but I will put the handout in there again right now in the chat box for those who are looking for it. And we have a nice reply, Cal, so I'm going to share the results.
Very good. Acute vision loss. Okay, great. All right, moving on to case number 3. This is a 67-year-old woman, and she presents emergently to a spot in her vision that's been there for 6 months. All right, so this is one of those things, well, I'm coming in because it's emergent, but how long has it been there? It's been there for half of a year. So you might think, oh, well, 6 months, nothing we really need to do anything urgent about. But we have to really listen and see what's going on. So she initially thought it was just smudge on her glasses, and that's why she waited and realized, okay, it's not going away. It's still there even when I take my glasses off. It's stable, it's stationary. She doesn't really have any past eye issues. There's no significant social history. She has, quote unquote, what she calls borderline diabetes. She has high blood pressure, high cholesterol, for which she's treated, and osteoarthritis. She's never had any trauma to her eyes. She's never had any thyroid problems. Nothing else significant that she can think of. So here are her afferent findings. So her best corrected vision is 20/30 in the right eye, 20/25 plus in the left. And she does have a very significant APD in that right eye. So, I mean, you do just a 1-second swinging flashlight test. You go from the left eye, shine the light in, it constricts, you come over to the right eye, and we get that immediate escape. But despite that, she still has normal color vision in both eyes by Ishihara. Confrontation fields, though, do show inferior constriction in that right eye. And here is her optic disc appearance. So the photos are a little bit dark, but when we looked in clinically, we questioned, it wasn't even definite, we questioned if there was some trace temporal pallor in that right eye. So you can see these are a little bit tilted, got a little bit of peripapillary changes, but and the cup's kind of moderate size, but when you look at the pictures, it looks nice and perfused. Again, looking in, we just questioned if there was a little bit of temporal pallor in the right eye. And now we have another OCT that we're looking at. And when we look here, we'll start at the picture in the center bottom. This is the RNFL. And when we look at that, we're seeing that the right eye, the one in question, when she's saying really has changed, we're seeing some thinning, right? We're seeing thinning inferiorly and temporally. You might say, oh, well, there's one little area here in the left eye that's actually red. Isn't red kind of worse than yellow? Well, first of all, we're going to go to the average RNFL thickness, and the average is lower in the right eye. And what happens sometimes on the clock hours, because if you look above it at the quadrants, they're all within the normal range. So sometimes what happens with a clock hour here, and this is between superior and temporal, sometimes you get kind of like a split bundle. So some of it's going to be a little bit thinner and some of it's going to be a little bit thicker, right? So this is a 68, but this is a 131. So it kind of gets split and shifted a little bit. Okay, so you want to look at all of it in combination and not just say, oh, there's one little piece of red there. Okay, but the more concerning is the right eye, because we have two of these quadrants that are thin, and this is showing some areas of thinning, and overall average is as well. And then when we apply this to our ganglion cell analysis in the upper right, that's showing that we really have thinning of the ganglion cell And remember, it's the axons of the ganglion cells that become our retinal nerve fiber layer. And this is showing that there is significant damage, it's permanent damage that's happened here. And now we have to figure out why. So if we look at the visual field here, and we can see the mean deviation is written bigger at the bottom so that you can see it. And as we were alluding to earlier, the eye that has the bigger negative number is going to have the APD. And you basically subtract the absolute values of this, and then it's going to be roughly about a 1.4 log. And we saw it, I think we said, to a 1.5 to 1.8. So it does match pretty well, okay? So here we have this unilateral visual field loss. And you might say, is this respecting the vertical like we had earlier? You know, we had that patient with the pituitary adenoma where one eye was just respecting the vertical. But you have to keep in mind, in that patient, the other eye still had field loss. Now, granted, I have seen patients where it's just beginning of a pituitary adenoma and one eye is affected before the other. But this is not completely respecting the vertical. Parts of it look like maybe it could be, but then there's, you know, enough of a defect on the nasal side as well. So we're still thinking about where is this problem, seeming to be more optic nerve than chiasm. We have to look at the rest of the exam to see what's going on, and do we see anything else abnormal? Well, when we do our efferent exam, we see that there's a supraduction deficit in the right eye, only 75% normal supraducting capacity. And that matches with a left hyperdeviation that we see on cover test that gets worse in superior gaze. So, you know, we have somebody with afferent issue and an efferent issue in the same eye. And when we think about that, that pretty much localizes to the orbit, okay? So we really have to think about that. And we did a forced duction test, tried to get that eye to move all the way up, and it was positive. So that really localizes to the orbit. When we say it's positive for a suction test, it's positive for a restrict process. So we have to think about what could this be. So pivotal in this case was the ductions, the cover testing that really told us that this is an orbital process, not just an optic nerve process, intrinsic optic nerve process. This seems to be more of something taking up space occupying lesion in the orbit. And you might say, well, could it be thyroid eye disease? Potentially it could. You might say, well, isn't that always bilateral? And it doesn't have to be. So thyroid eye disease is one thing on our list of differentials, but so is any other type of a space occupying lesion in the orbit. And for it to be so bad, if it was thyroid eye disease, to be causing an optic neuropathy and be purely unilateral with no other features is probably a little odd. So what did we do? First thing is we got imaging. So we ordered an MRI of the orbits, and keeping in mind when you're ordering MRIs, there's an MRI of the brain and there's an MRI of the orbits, which are two different studies with two different CPT codes. And oftentimes we are doing both of them together, but sometimes insurance does not allow you to do both. So if you had to only do one in this case, because of how it localized, you would opt to do the MRI of the orbits with and without contrast. And that is what was done here. And the top pictures are axial images and the bottom pictures are coronal images. The pictures on the left are without contrast and the pictures on the right are with contrast. And we can see that there is this enhancing lesion within the right orbit. And here, if we look at this picture down here, this little gray circle is the optic nerve. And then we have this large enhancing mass around it. And if you're not used to looking at MRIs, just so to clue you in, of course, we have all of our extraocular muscles in the orbit surrounding the optic nerve. And those normally enhance with contrast. So it doesn't mean that they are abnormal. That's just a normal effect of the contrast, the optic nerves get, the extraocular muscles get bright. Okay, so that is normal that they are enhancing, but it is not normal that we have this mass here around the optic nerve that isn't. And this
So
is
a question rolled in here, Cal, is the fat suppressed?
Yes, it is. So anytime that you are going to do an orbital MRI with contrast, they will do fat suppression of the orbit. Because what happens is, as you see here, when something enhances, it comes out bright, right? Now, fat, normally, as you can see on the upper left picture, is normally bright. So if they left that fat there and then tried to see if there was enhancement of the nerve, it gets hard to see the white next to the white. And is it just some fat that we're seeing, or is it really enhancement? So what they do is they suppress the fat whenever you're going to do contrast, so that now you can see the enhancement of this meningioma. You can see it much easier next to the dark fat. Okay.
So a question I have, Cal and Joe, is, every time I've ever heard a lecture, and you guys have more neuro experience than me, I've never heard of a benefit of not fat suppressing. I think you have to fat suppress in every time you're ordering contrast. At least that's in my.
Yes, but I mean, they're going to do it regardless if you order it or not.
Okay, that was my thought. So,
yes.
Okay, thank you.
Yes. Right, because the radiologist is going to want to be able to see if something is enhancing, because this is very large enhancing mass in the orbit, right? Sometimes we're looking for some really small things as well. So they want to make sure that you're going to see it. So this is a meningioma of the optic nerve sheath. And this is a very big meningioma of the optic nerve sheath. We have to remember that we have, of course, meninges surrounding the brain, but we also have meninges following the optic nerve, right? And it's within that meninges, in the subarachnoid space, that we have the fluid that built up in the first case when we had that increased subarachnoid fluid. That was the papilledema. But we can also have these cells proliferating in the meninges, giving us a meningioma, as we see in this case.
So don't
Kelly?
go forward, because there's a question that rolled in that says, could you see this without contrast in a case where you can't give contrast? And I think your images on the left there are
Yes.
without contrast, and you
they
can kind of see it, but maybe walk us through that.
Sure. So yes, this one is large enough that you can see this kind of circular region here. So the optic nerve should just usually be just as you can see on the other side, just a long area here. And you can see the circular region that tells us it's too large in this region. But then when we go down here, this is a T2 weighted image because the fluid is bright. So we're not seeing increased fluid here as you would in papilledema, but we're seeing that there is a mass, and we can see the optic nerve is kind of pushed downward compared to the other side. So this is normal on this side. We should have the optic nerve being that gray area with a little white around it, which is the normal amount of subarachnoid fluid. Here, we see the optic nerve, and then this larger area. This is not fluid, this is a mass. So yes, if you couldn't do contrast because of maybe they're on dialysis or some other reason, then you could still see it in this case. Sometimes an optic nerve sheath meningioma is kind of like, they call it a railroad track sign. So it's just kind of right along the nerve. So it's just a little bit of proliferation, and it may be hard to see without contrast, but in this case. All right, so the question is, what do we do with this patient? Where do we send the patient now? Or do we send the patient somewhere? So what would you do at this point? Would you say, well, it's a meningioma. I don't think they're going to go in and cut it out. It's attached to your optic nerve. The optic nerve function is still pretty good. I'm just going to follow them. And if so, are you going to follow them yearly, or are you going to say, okay, come in 4 months instead so we can see if it's been worse? Or are you going to say, no, I need to send you to somebody? And if so, who's it going to be? It's in the orbit. Are you going to send to ophthalmology? But it's a meningioma, so it's meninges. Are you going to send to neurology, or are you going to send to neurosurgery? Who would be the appropriate person if you were going to refer, or would it be best to just monitor them? So let's see what everybody says.
Poll was launched. We got about a 65% reply. I don't see any other questions in the chat box. The handout has been launched twice. I think we're rolling along just well here. We're like Delta. We're at 36,000 feet and cruising altitude.
Good.
Okay, a few more weigh in. And okay, we're gonna think we got the trend here, Cal. So we'll show you the results.
All right. All right. So looks like we're number 1 is referred to neurology. Number 2 is referred to neurosurgery, followed by referred to ophthalmology. So not many people want to just follow this on your own. And I think that's very good. But we're still going to be following them from the eye standpoint, because we're going to be the ones saying, are they getting worse from an afferent and efferent standpoint, but not solely us following them, right? We're going to refer as well. And the question is, who are we going to refer to? Who really owns this space? And the answer to this is neurosurgery. Okay, so neurosurgery is going to be who is going to be monitoring an optic nerve sheath meningioma, and they're going to be the ones deciding if any treatment is needed. So we did co-manage this with neurosurgery, and they decided that what was needed at this point was just watchful surveillance. So in other words, they just want to monitor the patient. And, she's had symptoms for 6 months, but we don't know how quickly this has progressed. If it's staying stable, they're not going to do any treatment, right? If it starts to worsen, then they will do treatment. And the question is, what is the treatment going to be? I mean, this is kind of wrapped around the optic nerve. So they're not going to go in and surgically remove it. The treatment would be radiation. And, this is right next to the optic nerve. So if they're going to do radiation, there's a chance that the vision can get worse. So they have to weigh the risks and the benefits. And that's why they're thinking watchful surveillance is what they need to do unless the vision worsens. So we're cruising along. She's doing well. We're monitoring her. She's monitored by neurosurgery. And then I get a phone call saying, oh, my vision's getting worse. I'm seeing more double vision. Now, keeping in mind, she wasn't really noticing double when she came in, but then after that, she started to realize, yes, I was seeing some double. We gave her prism in her glasses. That solved her problem. She was doing fine. But now she's saying, I'm noticing horizontal double vision. Now remember, she had a hyperdeviation because she had a right superduction deficit. So now she's saying, I'm noticing some horizontal double vision. And she told this to her neurosurgeon, and they said, oh, things are getting worse. This is growing. So she was scheduled to get fit for a mask, a radiation mask, in preparation to have radiation, because this was presumed to be an optic nerve sheath meningioma that has worsened. So what would you do at this point? I'm not sure if this is a poll or not.
I did not put this one in, Cal.
Yeah, are you going to tell the patient, well, they said you need radiation. You need radiation. Go ahead and do it. Are you going to say to the patient, well, go ahead and do it, but come in and see me. Let's just get baseline testing first so we can tell how you do. Or are you going to say, well, wait a minute, just come in and see me. Let's get this quick before you even do anything with the radiation, because let's see if you really need radiation. And you might say, well, how could we even come up with C, right? We're not neurosurgery. How are we going to determine if radiation is necessary? Well, we're not going to be the ones to determine if it's necessary, but we're going to be the ones to determine if she really got worse, right? So the answer that we told her was C. So she comes in, and so she's 60 superduction, 60% normal in the right eye. She was 75 before. Maybe that worsened a little bit. That'd be hard to say definitively, but she's not complaining of that. She's still in her prism and for her vertical misalignment, and she's not really having any more vertical double vision. She's complaining of now horizontal double vision. And you can see, not only does she have the right superduction deficit, but what is the reason she's complaining of? She has an abduction deficit in the left eye. And now she's 20 ESO in left gaze. So did her optic nerve sheath meningioma get worse? Well, that's not what we're seeming to be concerned about. This is in the other eye, right? So we're like, hold the presses, don't get fit with this mask. Let's see what's going on. So making sure that you do ductions and cover testing in different positions of gaze, very important, okay? Not just in primary gaze, because you're going to say, oh, that's not really too concerning, but you need to do it in all positions of gaze and really do those ductions well, okay? So we say, well, radiation is only going to be warranted if the optic nerve sheath meningioma progressively worsened, but this is the problem in the other eye, so you're not going to need radiation. So what do we do? Well, we got another MRI to make sure, and the optic nerve sheath meningioma was reported to be stable, but what was found is a new arachnoid cyst. As you can see here, it's a cyst, so it follows the fluid. So therefore, when fluid is bright, as you see here in the vitreous, the cyst is bright. And when fluid is dark, as you see over here in the vitreous, the cyst is dark. So it's medial in the cavernous sinus. And remember, we said sixth nerve is most medial in the cavernous sinus, right? 3, 4, V1, and V2 are lateral. So this is an arachnoid cyst that's, cysts can expand and get bigger and get smaller. And when it gets bigger, it can push on cranial nerve 6, and this is on the left side. So she does not need radiation. And we called and we spoke to neurosurgery and neuro-oncology, and they then agreed. And so she did not have to go through with radiation, and she was very thankful to that. So it's very important to, make sure you're on board and part of the team, and that you make sure you get the patient in to see their reports of worsening. Is it really from the same process? Okay, so very important.
We had a question roll in from a fellow colleague that has lectured for us, working at a school, Carolyn Major, saying, how frequently would you repeat the MRI after the initial presentation for the meningioma case?
For this case here we just did, right? Yes.
Yep.
So that was all left in the hands of neurosurgery, and they were deciding on how often to repeat it. So that was just left up to them, and this was now only repeated because there was this change. So I wouldn't be the one deciding that, they would, but when there's a new change with something new going on in the other eye, then it warranted us getting another. All right, moving on to case number 4. This is a 93-year-old woman with a sudden onset of vertical double vision that she has had for a week. It's both far away and up close, and it's true double vision. She closes an eye and it goes away. There's some blur associated with it. She also feels that her left eyelid, upper eyelid, is a little bit droopy for about a week as well, and she's having some eye pain for about a week. She also reports some generalized weakness for about a week. Now she's 93, but when we ask her all these things, this is what she admits to, and everything seems like it's happened a week ago. Systemic history-wise, you can see there high blood pressure, high cholesterol, some arthritis, had ovarian cancer, but it was 30 years ago and has not had any issues since. So we're left with vertical double vision, right? We're assuming there's some vertical ocular misalignment, and have to think about what could it possibly be? What are the things we have to think about? Well, first things on our list are going to be things like a third nerve palsy, a fourth nerve palsy. Of course, we have to think about a skew deviation that could happen from stroke, and she's certainly at that age. Could this be myasthenia gravis with her weakness that she's talking about? Could this be thyroid eye disease? Could she have had some trauma, although she denied it? Could it be a mass? So let's take a look. So her vision's pretty good, 93-year-old, as is her color vision. She has no APD, confrontation fields are full. Her DFE looks great. We do a neurologic exam, as we do on our patients, and she did have some mild left upper extremity weakness. Hard for her to say how long it's been there. She thinks everything's been a week, but really hard to say. So when we talk about palpebral apertures, we did measure them to be asymmetric. So 11 in the right and 7 in the left. Exophthalmometry was 17 and 18. So, is there ptosis? There's definitely some asymmetry of the lids going on here. But the main things we'd be thinking of is this Horner syndrome, third nerve palsy, myasthenia, disinsertion of the levator. So there's things in orange would be the particular conditions, the things kind of in the lavender color. They're just the types of ptosis that we have to think about. Whenever there is potential for ptosis, we always have to think about the pupil size. Is there anisocoria? And if there is, whenever there's a smaller pupil on the side with the smaller lid, you always have to think, could it be Horner syndrome? And the bigger pupil on the side with the smaller lid, we always have to think, could it be a third nerve palsy? But in this case, pupils were isochoric, so there's no suggestion of an autonomic nervous system problem. All right, so now let's get to the motilities, right? So when we take a look, this woman, similarly to the last case, cannot fully look up, but this time with the left eye. So she has a left supraduction deficit. Other ductions look pretty good. All right, so we called it about 60 to 70% of normal. And of course, when the left eye is not going up, that gives us a right hyperdeviation. It's going to get greater the further up we look, and that's the pattern that we see here. So we're going to have to try to figure out what this is and what could it be. So what is the cause of this supraduction deficit? And these are the main contenders here. Is it going to be a third nerve palsy? You might say, well, I mean, there's no problem with infraduction. There's no problem with adduction. Well, it could be a partial 3, but it could also be a superior division 3. Remember, cranial nerve 3 separates into a superior and inferior division. Superior division is levator and superior rectus, both of which could be a problem. This could still be myasthenia gravis, of course. We have to consider thyroid. You might say, well, why? There's a ptosis. We don't get a ptosis in thyroid, but you know, it's still going to be on our list for the supraduction deficit. Could be a skew deviation. Again, wouldn't really account for any potential ptosis, but we're really not sure if this ptosis is related, or is this just an aponeurotic ptosis? I mean, that's an age-related type of ptosis. She is 93. So we still want to consider the things that just give us the supraduction deficit and not just say it has to either be a 3 or myasthenia gravis, and then we'd not be considering anything else if that was the case. We don't want to miss something, assuming that there is a ptosis that is caused by the same process. And we have to consider a 4 as well. So when we think about these, we have to think about how could we differentiate among these. Well, a forced duction test could potentially be helpful if it is restrictive, right? If we see it being restrictive, as we did in the previous case, we'd say it's an orbital mass or thyroid eye disease. And then we could also use torsion to help us. We have a vertical misalignment of the eyes. And if that's the case, if there is torsion, if the higher eye is intorted, that would be consistent with a skew deviation. If the higher eye is extorted, that would be consistent with a fourth nerve palsy. So those are the things we have to consider. Now, we've been talking a lot today about are things urgent or emergent, and 2 things on this list would be, right? Sometimes you can have reasons where other things could be, but a third nerve palsy, definitely we would have to consider an aneurysm. And then skew deviation could be from a stroke, especially in this age group. So definitely would be something to think about urgently as well. So we tried doing our forced duction test. And forced duction tests are easier to do, not just do, but easier to really tell the results when we're doing it horizontally. Because you look for that scleral show, and then you slide the eye over and see, okay, well, I don't see any more scleral show. So now I know I've moved the eye all the way over. When you're talking about doing it vertically, the eyelid is kind of in the way, no matter how much you lift it up, right? You're not really getting that scleral show and then seeing how much you can move it. So it's a lot harder to really tell, especially if it's, you know, if it's a 0% supraduction, then yeah, you can tell. But in a case like this, it gets a little tough, right? So we couldn't say with certainty if it was negative or positive. So it was considered equivocal. So in other words, it wasn't really a helpful test. There was no torsion on double Maddox rod testing, so it did not seem to be consistent with an acute skew deviation or acute fourth nerve palsy. So the question is going to be, would we consider this a medical emergency or not? And there's, still probably a lot of question in your mind. But at this point, what would you be thinking?
Okay, medical emergency question has been launched. Yes or no? Nothing's rolling in. They're not seeing it on their end?
I'm not seeing it, no.
No, let me see. Let me
You
try
see it?
this one.
But
see it?
nothing's rolling in.
There we go. So we have this 93-year-old woman with a left superduction deficit and asymmetric palpebral apertures with a smaller aperture on the side of the superduction deficit. She reports some pain, but her pupils are isochoric, and that's kind of where we stand at this point. So what would we think?
So everyone had time to think about it. So that was a quick reply. Thanks, everyone. I'm going to end the poll.
All right. So we're pretty evenly split with more people saying probably not a medical emergency. All right. So what do we do? Well, could it be a partial third nerve palsy? We can't say that it's not at this point, right? I mean, the pupil's not blown. If it was, we'd be saying, okay, it's going to be definitely that. But it could be partial. Okay, so we can't rule it out. Now, we didn't send her right to the hospital, but we did get an MRI and MRA to rule out. Also, remembering that a third nerve palsy could be caused by GCA. So we had to get our sed-rate C-reactive protein as well. She's 93 years old, complaining of a little bit of pain. So we definitely did that as well, but we wanted to rule out other causes of double vision as well. So we did some other tests. We tested for the typical things we would test for in terms of double vision. So Lyme disease, syphilis, ACE for sarcoid. We did tests for myasthenia gravis, acetylcholine receptor antibodies, just started with the binding, blocking, and modulating. And then we did tests for thyroid as well. TSH, T4, and then the thyroid antibodies. And when we got it back, the MRI report did not show any aneurysm at all, thankfully, but there was prominent orbital fat and then some fatty infiltration of some of the recti muscles bilaterally, even though she really only had a superductive limitation in the left eye. And her lab testing showed abnormal TSH. It was elevated. And remember, when the TSH is high, that indicates hypothyroidism. Okay, and then she had the antibodies elevated, the thyroglobulin and the thyroperoxidase antibodies, which go along with hypothyroidism and Hashimoto's thyroiditis. So this is an example of Hashimoto's thyroiditis. We have to keep in mind that when we see thyroid eye disease, we tend to think about it with Graves or hyperthyroidism, but remembering that it can happen with hypothyroidism and even with euthyroidism as well. So important to keep that in mind. So we sent her to endocrine. They started her on levothyroxine, and we're going to see how she did here in a minute. But it's important to keep in mind that we still needed to rule out the aneurysm because we couldn't say that it wasn't a third nerve palsy.
No, I don't recall. I had to get some more tea. I was coughing. Did the patient have headache or head pain?
Yes. So she complained of, I'll go back to see exactly how she worded it. Eye pain for a week. No significant headache, but eye pain.
Okay. Is the absence of headache leading you away from aneurysm?
Yeah, that's why we didn't do it like emergent to the hospital, but we
Mhm.
still did a scan. Yes. But yeah,
Yeah,
the abscess.
I had a person like that. He was 94 years old.
Mhm.
He had a partial third. He had been dilated by the time I saw him,
Oh, yeah, that's hard.
so I couldn't look at the pupils. But he didn't know what a headache was. He said he had never had head pain in his life. So, as I expected, he turned out to be ischemic.
Right. That brings up a good point. You know, if the patient's already dilated, in that case, if you're really trying to see, you know, is there a dilated pupil? Because in that case, you're saying, yeah, this is aneurysm, you know, send it right to the hospital. Sometimes just putting in a pilo, because it will constrict a third nerve palsy pupil, but not a dilated pupil. So sometimes that's helpful.
No, no, both eyes have been pharmacologically dilated before I even saw the patient.
Okay, right. But yeah. Oh, so you already knew that. I see. I got you. Yeah.
Yeah.
Okay. All right. So let me go back to where we were. All right. So what about the ptosis, you might be saying? If this is thyroid eye disease, that doesn't have ptosis, right? So this really was a pseudotosis, and it was actually the other eye that was retracted. So when we think about eyelid retraction, as we know, that happens in thyroid eye disease and in dorsal midbrain syndrome. And this is the 6-week follow-up, and the only treatment that she had was the levothyroxine. So she didn't have any treatment for thyroid eye disease, just for her underlying thyroid dysfunction. And you can see that now she's able to superduct much better. Her diplopia is gone, and now her lids are symmetric as well. So this is mild thyroid eye disease, and we have to, you know, realize that majority of those do regress with just achieving a euthyroid state. So if you can catch the thyroid eye disease early, when it's mild, you know, they do really well sometimes just with getting their thyroid under control. So the thyroid antibodies can be very helpful. And the two that were elevated in this woman were thyroid peroxidase antibody and thyroglobulin antibody. And those are the two that tend to be elevated with Hashimoto's. And then we don't use those to monitor the response to treatment. In somebody with Hashimoto's, we would use the TSH and the T4. But in Graves' disease, the antibodies that we look at are TSI, thyroid stimulating immunoglobulin, and TRAB, or TSHR, however you want to say it. It's used both ways, and that's the thyrotropin receptor antibody test. And those antibodies are used to assess response to treatment. So they'll repeat them to see how they're doing. So keeping in mind that even though thyroid eye disease is more common in Graves', we do see it in Hashimoto's, as we said. And that Hashimoto's is very common in elderly. So you want to keep in mind that you're going to be looking for features of thyroid eye disease in patients, even if they don't have known history of thyroid dysfunction. You ask them in the history to make sure, you know, see if you can pick up anything early. Remember,
Yeah, so from my thyroid lecture, I always say if we have a thyroid eye disease support group and we had 100 people in the room and you asked them how many people were here because they have thyroid eye disease, it's a thyroid eye support group. How many were hyper at the time of diagnosis? 90% would raise their hand. And
right.
then the other 10% would be euthyroid and the other 10% would be hypo. So kind of a little bit of kind of echoing what you're saying, just by putting some numbers to it.
Yes. So the features that we can see for thyroid eye disease, you know, red eye, the eye being inflamed, the lid edema, proptosis, problems with motilities, and of course, so that's all a lot of efferent things there and a lot of health of the eyes, but we have to keep in mind that it can become an afferent problem as well if there's compression of the optic nerve. Keeping in mind also, when we have an efferent problem, most likely it's an inferior rectus. That's the most common muscle to be affected. But we also have to keep in mind, this is the belly of the muscles that get enlarged. If you think about the globe and the belly of the muscle kind of being in the back of the globe, remember where the globe is looking, front of the eye is looking, the back of the eye is going in the opposite direction. So if the back of the eye is hitting against the inferior rectus, that means the front of the eye is going upwards. So if they have an inferior rectus muscle that's enlarged and infiltrated, they're going to have difficulty in up gaze. So that's
Kelly,
consistent.
is there, when I lecture and I talk about the inferior rectus is usually involved, is there any scientific, any anatomical, any why the inferior rectus? I mean, I know it is from literature, but why the inferior? Is it like, do you have any explanation?
No, I don't have any explanation for that.
I don't either. So I was
Yeah.
leaning on you for some insight.
Second is medial. But medial, there is kind of like an explanation as to why, not so much medial is second, but when the medial is involved, it's more likely to cause the optic neuropathy because they kind of share a common chief, the medial rectus.
Okay, thank you.
You're welcome. We all know that tobacco use is not good in somebody with thyroid dysfunction and specifically with someone with thyroid eye disease. So we need to make sure we educate our patients on the worst prognosis of thyroid eye disease with smoking. So even if you have patients that don't have thyroid eye disease yet, and they just, in their history say they're hypothyroid or hyperthyroid, you want to make sure, find out if they smoke. And even if they're around secondhand smoke, that could affect them as well. So you want to make sure you educate them. Also, we need to make sure everybody is aware of the newer classifications. These have been around for several years now, but depending on when you went to school and graduated and what type of CE courses you've taken, you may or may not have heard of these. So it's very important now, since there is a treatment for thyroid eye disease. We have to not only tell is it mild, moderate, or severe, but we have to tell is it clinically active. That's going to be very important. So the clinical activity score, as you can see kind of on the left side here, that's based on the UGOGO criteria, okay? And there are 10 features or factors that we're gonna look at to tell if somebody has active thyroid eye disease. If they're a first-time patient to you, you're only gonna use these top 7 things, 2 of which are subjective. So you're gonna ask the patient, do you have pain? You have to ask if they have spontaneous pain, orbital pain, and do they have gaze-evoked orbital pain? They would get a point for either one of those things, or both. The next 5 components of that are things that you objectively look for. You look to see that they have swelling of their eyelids, that typical jelly roll type of edema. Do they have erythema of their eyelids? They're 2 separate categories, 2 separate points. Do they have redness of their conjunctiva, chemosis, and then inflammation specifically of the caruncle or the plicus lunaris? You add those up. They have to have a score above 3 out of 7. I don't know why they don't just say at least 4 out of 7, but so you need 4 out of 7 of these to be considered active. And that's going to be very important for the new treatment for thyroid eye disease. It's only indicated in active thyroid eye disease. And then if it's a patient that's coming in to see you in follow-up, you would do all those 7 every time. And then you add 3 more. And those 3 more are looking at the proptosis, because your first time was just a baseline test, and now you're trying to see, did it change? If there's an increase in 2 millimeters in proptosis, they get a point for that. If they have decrease in their adductions in any direction by 8 degrees or more, you get a point for that. And if they have a decrease in Snellen acuity by 1 line, at least, they get a point for that. And on any follow-up visit, they have to have above 4 out of 10, which would be at least 5 out of 10 to be considered active. The reason we need to
Hey, Cal, go back real quick so I can just kind of give a clinical pearl here is that, you know, we were all taught kind of no specs back in school. The no specs doesn't really tell us, as Kelly's mentioning here, the activity. So what we want to do is use the clinical activity score. So you're like, oh, now what do I got to do? Most of us have computers in our rooms. You know, I don't tell you to print it out and hang it up on the wall or anything like that. You know, just remember the words clinical activity score. You can Google that. This will pop up right here. You see that's the first time that they're in. You see the 7, you count, you know, look at it, say, oh, the patient has pain. They have, you know, pain on when they look. They have some swelling. Oh, we got the 4. Boom. That's now when you can consider using teprotumumab or Tepezza. So.
Yep.
Okay, I'm good. Thank you.
All right. And Rundle's curve, this is part of the reason we need to identify active thyroid eye disease and get them on the treatment that's now available, because it's been shown that if people are not treated when they're in the active phase and they're allowed to progress, they're going to need more surgical interventions. We also have to remember that it can be a sight-threatening problem if it starts to compress the optic nerve, and that's when it becomes a medical emergency. You have someone that has optic neuropathy from compressive thyroid eye disease, they need to go right to the emergency department for IV steroids and potential urgent orbital decompression surgery. Otherwise, what could you do if it's not something that's emergent? They don't have the optic neuropathy. Well, if they have some diplopia, we know we can treat that with prisms or patches. We know we're going to treat their dry eye. We're going to tell them to sleep with their head elevated and stop smoking. Yeah, we're going to do all those things, right? But that's not going to help their thyroid eye disease get better. We're just kind of putting the Band-Aids on it, right? So what else can be done? Well, we've always had steroids and we've had steroid-sparing agents, and sometimes if it gets bad enough, we've had orbital radiation or decompression. But now, thankfully, we have a treatment specifically designed for thyroid eye disease in the form of teprotumumab. And this is the first FDA-approved medication, and so far still the only one approved for thyroid eye disease, approved since January of 2020. And it is administered by IV infusion. It's a monoclonal antibody, and it's given every 3 weeks over 8 infusions. And a study was done called the OPTIC trial that looked into this. And it was done to look at the endpoint of proptosis reduction. So that's what was studied initially. And it was found that after the 24 weeks, patients did have at least 2 millimeters reduction in proptosis. So it was successful at reaching that primary endpoint in the OPTIC trial. Since then, studies have been done to look at what else it does. And not only does it decrease proptosis, but it's been successful in eliminating diplopia, reducing orbital pain, redness, and swelling, and also improving visual function and appearance. So it's been very successful. I've had several patients on it and they've done very well. So it's great that we have something now other than just steroids, that we really have a treatment designed for specifically thyroid eye disease. But right now it's only approved by insurance. It's only considered to be approved by insurance for those that are clinically active. Okay, so if your patient is not clinically active, you wouldn't consider it as a. You have to keep in mind that there are some things that have to be considered as precautions in people that you're going to suggest this medication for. You always want to ask the patient if they have any history of irritable bowel disease. It can exacerbate that, and they could have flare-ups of the condition while they're on the medication, and to the point where it may need them to discontinue the medication. It also can increase blood sugar. So blood sugar needs to be checked on all patients before they start this treatment, and they also have to be monitored for their blood sugar during the treatment as well. 10% of the patients that are on it have hyperglycemia, and it's not just the pre-existing diabetic. And they're the ones that usually are checking their blood sugar all the time anyway, so usually they're more concerned about the non-diabetics because they're not used to even checking their blood sugar, and sometimes it's pretty high. Other adverse effects have been noted, things like muscle spasms, nausea, vomiting, diarrhea, headache, but mainly it's the IBD and the hyperglycemia that are concerning.
So Cal, recently I was watching while I launched this polling question, I was watching the TV the other day. Oh, why won't this launch? Let's see. Polling question number 3. Oh, it won't launch. Has been launched in this meeting, it says. Let me see if I can relaunch it.
That's okay.
Yeah,
We can
it won't
skip
work.
it.
So we know it's inferior, but I was watching a TV, watching it, and it came on that, hey, if you have hearing loss from teprotumumab, we might have money for you. So I reached out to the MSL and they said, look, it's a known side effect. And So they said pretty much that if they already have some hearing loss, that it could make it worse. So sometimes now the docs that are doing the infusions or before doing the infusion will order a hearing test now. So
Yes.
just FYI, in case people see that on TV. So
Right. Yes, it can be that. Sometimes it's just like a tinnitus where they're just complaining that they're hearing a ringing in their ears. So it's different thoughts as to what it could be and different for different people. All right, moving on to case number 5. This is an 84-year-old woman with an ocular history of, it's pretty significant ocular history. She's got glaucoma in both eyes. She has Fuchs endothelial dystrophy to the point that she had a penetrating keratoplasty in the left eye. She's also had a branch retinal vein occlusion in the left eye for which she's undergone focal laser treatment. Systemic history is remarkable for diabetes, high blood pressure. She's had a heart attack. She's had coronary artery bypass graft, arthritis, and anemia. So her visual acuity has been reduced because of everything that's going on. Best corrected, she gets to 2200 and 2400. And she got a lot of still because she's had the corneal transplant. And this, I saw her before there was the SEC. So this was like a full thickness corneal transplant. And she had a relative afferent pupillary defect in the left eye and significant constriction in the left eye. So even though her vision is kind of poor in both eyes, she says, I've noticed that my left eye has gotten worse recently. So she's noticed this change, and the APD is new, as is the significant constriction in the left eye. And we take a look at her and we can see this presentation. So, the right eye, her cupping's a little bit large. She has a history of glaucoma, but in the left eye, now we can see she has disc edema. This is unilateral disc edema with a hemorrhage. And the edema is on the pale side as well. So we have to think about what potentially is this, what could this be? So we look at the causes of disc edema, and they are noted here. And some of these are more likely bilateral, like papilledema, and others can be unilateral. That would fit more closely with this case. So papilledema we're going to cross off because that has to be bilateral or at least asymmetric. Optic neuritis should not have hemorrhages, at least the majority in the optic neuritis treatment trial did not have hemorrhages. So if you see a hemorrhage with disc edema, you're going to have to think about something else. Optic neuritis is going to go lower on your list. Now you might say, why did we cross off NAION? And that's still kind of probably lower down the differential, but when we see this paleness to the swelling, this just happened and it's already this pallid swelling, we have to think it's more likely arteritic than non-arteritic.
And so, Kelly, there's no disc at risk in the other eye.
Exactly, right. Very good point. And then neuroretinitis, we would expect there to be this macular star, but remember that doesn't happen for about 14 days. So, I mean, we have an X there, but if she's presenting emergently, maybe we could say, well, that hasn't happened yet. But the fact that, we're seeing this pallid swelling and we're seeing hemorrhages, it's seeming more like AAION. Now, we want to ask some more questions, right? So we want to get a little bit more history. So her vision's been reduced now for about 3 weeks. She does have left temple pain, scalp tenderness, jaw claudication, malaise, recent flare-up of asthma. So, I mean, she's pretty much saying yes to everything that goes with giant cell arteritis, right? So that's mainly where we're headed. And she had all of these symptoms, which are related to giant cell, which you're probably all familiar with. So this is probably a pretty easy one for all of you. Which is this going to be? Is this a medical emergency or not? I don't know if it's worth launching the question.
I can do it. I think I figured out my error. So let me see if I can get it. Oop, that's not it. Hold on, back. It's right here. This one. Launch. There we go. I forgot to stop the sharing the other one. That was the issue.
Yeah.
And Cal, you're all caught up on questions here.
Okay. So we have this woman with apparent disc edema, well, obvious disc edema in one eye with hemorrhage, with large cupping in the other eye, so it's not a disc at risk, the pallid type of a swelling, we're thinking it's consistent with AAION, so would you consider that a medical emergency? And let's see what everybody says.
I think we've got the majority rolling in here, and I'll end it and share it.
Very good. So yes, we are considering this a medical emergency. This woman is leaving your office and going right to the hospital. And she had a stat SED rate, which was 125, so very high. You know, remember she was like, I think 84 years old. For women, you do age plus 10 divided by 2, right? I mean, she's definitely way above where she should be with 125. Her CRP is also significantly elevated, and her temporal artery biopsy was positive, right? So this is giant cell arteritis. She's treated with IV steroids. Just want to go over the difference between NAION and AAION, some of the differences. Now, sometimes it could be difficult to tell. Sometimes you get features that look a little bit more like one than the other. Sometimes it's a little more overlap, but they both can have hemorrhages. The difference, one of the main differences is we get this pallid disc edema in the AAION, whereas we tend to get more of a luxury perfusion, so it looks a little more pink in non-arteritic. And another key thing is what the other eye looks like. Is there a disc at risk? And in NAION, there should be, right? There always is. It's going to be a small crowded disc, and that's why it's predisposed to get this. But in arteritic, we don't have to have that. So you can have any kind of cupping in the fellow eye. But we're going to need to rule out giant cell arteritis with any disc edema or any acute vision loss in anyone over the age of 50. So keeping in mind that not every person with giant cell arteritis gets arteritic anterior ischemic optic neuropathy or even has visual involvement. Okay, so there are other things that can happen from giant cell as well. Everybody tends to just say, oh, the only thing we get, or the only thing we think of is AAION. But remember, you can have a third nerve palsy, fourth, sixth from giant cell arteritis. So when you have people presenting with those things over the age of 50, even if you're not sending to the hospital because there's a whole list of other things it could be, you still want to make sure you get your SED rate, C-reactive protein, etc., and ask all the symptoms, right? If they start saying yes to every symptom of giant cell arteritis, then maybe you are going to be sending.
Yeah, Kelly, that is very important to underscore. Last month, I had a 6th nerve palsy from giant cell.
Yes, very good that you thought about that. Because a lot of times it's on people's very low end of their differential because they're tending to only think of it as an afferent process. So very important that we think of it as efferent as well. So remembering that it's a vasculitis, and I kind of chose this case to put in here, not so much to go through the case, because it's a very straightforward case, but to use it as a starting point for talking about some of the new things in the realm of giant cell arteritis. So when we think about GCA, we know it's a vasculitis. We know that one of the things it does is produces cytokines, specifically interleukin-6. That's going to be important for the new medication now that is available to treat arteritis that we'll get to. We have to remember also, we tend to think of it as temporal arteritis. And yes, it does affect that area. And that's what we think of because we're dealing with the eyes. But remember, giant cell arteritis doesn't just affect the temporal artery. It doesn't just affect the eyes and the optic nerve function. It can affect any part of the body. So it's important to keep in mind. So we have to keep up with the literature on this because the stakes are so high, right? It can cause vision loss, it can cause death, and it's probably one of the major reasons for lawsuits against eye care providers is not catching it quickly enough, not treating it appropriately fast enough. So what's new? Well, there's some things new in diagnosis, treatment, and timing. This isn't as new, but it's still important. Keeping in mind that all vessels can be affected all throughout the body. It's usually going to be the large and the medium-sized vessels, but we have to keep in mind that it can affect the heart. So if you have patients with giant cell arteritis and they're not under the care of cardiology, you should be sending them there for evaluation, at least to establish care. They're at increased risk of aortic aneurysm. And if you have someone with giant cell arteritis that starts to have acute chest pain, you have to think about an aortic dissection. So it's definitely something to discuss with your patients if they're not under the care of cardiology. So who has giant cell? What do we do, right? We don't have a crystal ball, but we usually use the symptoms and the eye exam findings and the biopsies, which is historically done, and labs, of course. But now we're going to add into that mix. There's some, discussion about MRI could be helpful, but it's a little further out on the horizon. But ultrasound is really now something that is coming to the forefront, and so something we should be thinking about. So we have the old and the new in terms of the workup, and adding to this new, we're adding, they're finding that comprehensive metabolic panel can be helpful because giant cells can affect the liver function and the glucose. But what we're going to focus on mainly is the fact that we can now have a ultrasound that we can do of the temporal artery that could potentially help in the diagnosis. There's some caveats to that, which we'll have to discuss. Now, we could look at many vessels with the Doppler ultrasound, the large vessels, the medium vessels, but we're going to kind of focus on, so we're going to be seeing patients probably that have AION or have eye manifestations, and so we would want to look at the temporal artery. Now, whenever you talk about any type of ultrasound, it is very user dependent, right? It really depends on the skill of the technician. So this has to be done by somebody that's trained specifically to look for the features of giant cell arteritis on the temporal ultrasound. And you have to make sure you have someone that's very good at doing this. Because it's all dependent on them and how they do it. So it can have a very good resolution, and it's becoming a newer first line test for giant cell in the places that they feel like they have a very good experienced technician to do the test. But sometimes the doctor themselves to do the test. So something to think about and consider, and it's another option. So what do we look for in this temporal artery ultrasound? So as you can see the normal down here, you have this lumen and you see the blood flowing through it. It's a nice wide lumen, right? If you have giant cell arteritis, we know that the walls get thick, so the lumen gets smaller. And if you look at it on cross section, it's kind of a halo around the vessel and call it a halo sign. That's because of the wall thickness. If they see that halo sign bilaterally, it's very highly specific for giant cell arteritis. There's also the compression sign. So normal is A and B up here. So you see this vessel and you kind of push pressure on the probe and you can kind of collapse the vessel. Whereas if you have giant cell arteritis, you see the vessel and you put the pressure on the probe, but you can't fully collapse it because the wall is too thick. Okay, and that's the compression sign. So it's the halo sign and the compression sign that are looked for. Now, steroids can reduce the sensitivity of the ultrasound, right? So you'd want to get this test, if you're ordering it, done immediately, as soon as possible, before you start steroids or really early in the process of starting the steroids. Because if not, then you're not going to be able to really trust the results. So there are advantages and disadvantages. We can all really easily think about the advantages, like, less invasive than a biopsy, etc. Disadvantages, as I said, it's mainly the experience of the echographer, the interpretation of the results, and they're still kind of debating what constitutes a positive result. Where's the cutoff between, is it giant cell arteritis or is it not giant cell arteritis? So something to think about as we move forward in managing and diagnosing giant cell. Not the gold standard yet, but it's being used more and more often. So some articles and what they've shown on this, they are finding that it is a highly effective tool, but that caveat, it has to be a very skilled ultrasonographer. Okay? And in some cases, if it's done in the hands of a good ultrasonographer, it can have better sensitivity. Now, in terms of treatment, we have our old treatment, what was always done. Well, visual involvement is there. You're going to need to protect that other eye. They're going to be started on IV steroids as soon as possible. If there's no visual involvement, you need to protect the vision. So they're going to be on high dose steroids. It can't just be like a Medrol dose pack. It's got to be 60 to 80 milligrams daily. And keep in mind, even though there now is a treatment for giant cell arteritis, steroids are still the first line of treatment, especially in cases of vision loss. So it's not like we're saying, oh, we're not giving steroids anymore. It's just now we're giving steroids and something else. And that something else is tocilizumab, and it's been around for a little bit now. It was approved in 2017, and it is a monoclonal antibody directed against interleukin-6, which we started off this topic by saying, that was one of the things involved with giant cell arteritis. This is a drug that's not new in terms of it wasn't made just for this. It's been around and used to treat rheumatoid arthritis previously and as intravenous. But when it was approved for use for giant cell arteritis, it was approved as only a subcutaneous treatment. There are studies going on to see if it can be administered in different routes for GCA, but right now it's still just subcutaneous treatment. The trial that was used for this was the GIACTA trial, and this is giving the tocilizumab. It was given, they tried doing it every week and every other week, and then compared it to just steroids. So, and what did they find is they find that when patients were on tocilizumab, it delayed the time to get their first flare up and reduced how much steroid they needed to be on. So with that in mind, that was thought to be very good, of course. And when they compared the dosed weekly to every other week, they found that it was better when they were taking it weekly. So it's not used as a monotherapy. It's always used in combination with the steroids. And they kind of both cause T-cell responses, but in different ways. So two different ways to approach the solution is working better than just affecting the T-cells in one way. And now, the latest recommendations, as this is a 2022 article, is that tocilizumab is now recommended in all cases of giant cell arteritis that have visual involvement. Okay, so if there's no visual involvement, then they're just treated with corticosteroids. But as soon as visual involvement occurs, then the thought is that they should have tocilizumab. And if they have initially visual involvement from their giant cell arteritis, they should be on tocilizumab in combination with the corticosteroids. So now any patient that has visual involvement from GCA is on the dual therapy, or should be. And how about, what does it do in terms of the outcomes of the giant cell arteritis? Well, it's thought that using the combination of both can decrease the likelihood of permanent vision loss. And that's why it is now recommended anytime vision loss occurs, that they should be on the tocilizumab along with the steroids. Because it can protect against the visual complications, but once vision loss is permanent, it can't undo that. So we have to keep in mind that we are part of the team, right, that cares for people with giant cell arteritis. Rheumatologist is going to be involved, of course, treating the giant cell arteritis. We're going to have now referring to cardiology to make sure they don't have any type of aneurysm. And then, we have to get now the person who's going to, figure out what they need to be on. And that's going to be, rheumatology is going to figure out, are they going to be going on the tocilizumab? Neurology and the PCP are going to be very important as well, because if they're on the steroids, which remember this is combination therapy, they can be on less doses of steroids now, which is good, but they still have to be watched for their blood sugar spike. So in summary, what's new in giant cell arteritis? We've talked about ultrasound. If there's a good operator and there's a good, center that you're near that does this well, then you could potentially use Doppler ultrasound of the temporal artery as your first line. But at this point, biopsy is still going to be important because there are questions about the operator in some cases, right? Unless you're really sure that there's a good place near you. It's like if you're near a teaching hospital that's pretty big, then maybe they have that. So I'd probably that. And we'll keep on the lookout for it, because hopefully we'll get improvements in that as we go. And then tocilizumab is going to be very helpful in reducing the amount of steroids one needs to be on and helping to achieve remission. Keeping in mind, we talked about AION, we talked about efferent manifestations. But remember that somebody's first manifestation of giant cell arteritis may be transient vision loss. And so with any transient vision loss, even if they say my vision what happened and now it came back to normal, that is a medical emergency because it could be giant cell arteritis or it could be stroke. So as long as you're talking to the patient and you ask all the questions, okay, did it come back when you blinked? And make sure it's not dry eye or anything like that. If you can feel that this is true transient vision loss that happened, that is a medical emergency, and you're sending the patient to the hospital, nearest hospital with a stroke center, so that they can rule out stroke and rule out giant cell arteritis. So that's
Kelly, the use of tocilizumab and the dosing of steroids that you had earlier, it's very important for everybody to know that, because when I send these patients to ER with vision loss, knowing it's going to be temporal arteritis, I give them my cell phone number, and invariably I get a call back from the ER physician and or the hospitalist, and they'll ask what to do. Because they're intelligent, they're learned, but they don't have confidence or experience. And they always ask, what dosage do I use? So it's good to know that. Kelly, there's one last question. It says, are you saying steroid treatment will affect ultrasound earlier than biopsy? And what time frame do you get the biopsy after getting steroids?
So, I mean, it can affect both. But, historically, what I've always read and heard about in terms of the biopsy is you can still see the features of it for about 2 weeks. So you should get the biopsy within 2 weeks and you'd start them on the treatment. When we're talking about the ultrasound, it's seeming like what they're finding is that the effects of the steroids affect that more quickly. So you would have to get that earlier in order to it not be affected by the steroids.
Well, Kelly, I think that was great. I know I've seen your outline. I know you've only got through half the cases.
Yes.
So I think what we will do is in a few weeks, we'll bring you back for part 2.
Okay, sounds good.
So what was this last question? It says, I think diagnosed GCA after 50-year-old, why younger patients showing it?
Oh, I thought you were talking to me. I was looking for another question.
There's a question in the chat box.
I'm sorry, tell me again.
This looks like DDX, diagnosis of giant cell arteritis after 50 years old, comma, why younger ages showing it?
Oh, okay. I think what they're saying is, why are you considering it in someone that's 50 and not someone that's 80? I'm assuming like that's the type of question it is. So in other words, what we're trying to say there is you never would consider it in somebody less than 50. Like it's never been diagnosed in anybody less than 50. And that's why we just say that. I'm not saying that as soon as they're 50, you're really concerned about it, but when they're 50, you say that's a possibility. It's in your differential now. But you never your differential.
It's not new.
No.
It's just people aren't just aware of it.
Right.
Or another way to think of it is 50 is the new 80.
I hope not. It's not very common in 50-year-olds, don't get me wrong, right? It's still not common, but if you have somebody with vision loss and they're 50, you're going to say, oh, I need to see what the said-right C-reactive protein are to make sure it's not giant cell arteritis. You might do said-right and C-reactive protein in a, say, 40-year-old, but you're just seeing is there other types of inflammation? Because remember, those things are not specific tests. They're not specific for giant cell. They can be any kind of inflammation. So when they're elevated in younger people, you're saying, well, what inflammation do they have? And you have your list of inflammatory conditions, but you're not including giant cell on it. If they're over the age of 50, you are including giant cell on it.
So I'm sharing the last question here, but thanks, Joe. We got
yes, everybody. Let's wish a big birthday to Greg, my friend and partner. Greg, it's his birthday tomorrow, and I think you look fantastic for 64.
Yeah, not too bad.
Not even old enough to get GCA.
Yeah, thank you, Kelly. There you go. Kelly, one last question here, then I know we're right at that, over our 9 o'clock, but it's a good question. Do you wait for positive temporary biopsy or ultrasound to recommend starting Actemra, or start it at the same time the steroid when highly suspicious for GCA?
Oh, I mean, that's usually going to be in the hands of rheumatology to do that anyway. And right now, there also is another thing that they're starting to do with giant cell arteritis, and it's a fast track program. So you'd have to look in your area. There's so far only at a few hospitals, but hopefully it's going to happen more and more. So there are some big teaching medical hospitals that have a fast track program. So in other words, you look up on the website and says, this is our GCA fast track program. It has a phone number. You call them up and there's somebody answering the phone, and pretty much you tell them what's going on. And based on your conversation, they're going to decide how quickly they want to see the patient, what they want to start, etc. So it's a really great service to have. And I know that they are starting in some places scattered around. They've started in Europe more so, and it's starting to trickle its way into the US. So hopefully we'll have more and more of these fast track programs. It'll be very helpful for our GCA patients.
Well, Kelly, I've known you for years. We went to school together. We're just separated by a year. It's always been a pleasure listening to you teach. I've learned a lot over the years. Thank you very much for doing this tonight. As Joe said, we'll probably just bring you back here and kind of finish the other cases. I want to thank everyone for attending tonight. This is Neuro Ophthalmic Disease Cases. This was a synchronous virtual course. Again, Kelly, thank you. Joe, any final comments? And Kelly, you're getting your virtual round of applause in the chat box if you open it up.
Thank you both for the invitation. I appreciate it.
Everybody loves it, Kelly. I thought it was fantastic. And again, a great big OEC. Happy birthday to my partner, Greg.
Thank you, sir.
Happy
Thanks,
birthday.
everyone.
Take care.